TopMedTalk.
Well, hello and welcome to TopMedTalk. We're in Denver, Colorado for the Society for Obstetric Anesthesia and Perinatology, or SOAP. I'm Desiree Chappell, co-editor-in-chief of TopMedTalk and your host today. And joining me is former editor-in-chief and my partner in crime, really, Monty Mythen. Hello,
Desiree,
Monty.
thank you for letting me back in the chair.
I did.
Now we're gonna dive straight in because we managed to grab a very special guest.
It's a former SOAP president, Dr. Mark Zakowski. Hi, Mark. How are you?
Hi, great to be here, and thank you for coming to the meeting.
Former president of SOAP. It's a fabulous organization. The meeting's been absolutely fantastic. Our first time here, and SOAP has, graciously given us this booth in the exhibit hall, which is very cool. But a fantastic organization. Why don't you tell us just a little bit more about it?
Well, SOAP is the premier organization for the subspecialty of obstetric anesthesia. It works closely with other organizations such as American Society of Anesthesiologists, Obstetric Anesthesiology Association, Society for Maternal Fetal Medicine, American College of OBGYN. So they specialize in what's the cutting edge science, how can we put out the best practices.
Yeah.
And having participated, I've come to every SOAP since 1989, except the 1 year I took my mother for chemotherapy.
Oh,
But so it's a close-knit community, very dedicated to the science and really advancing the practice and taking care of patients and improving care for all moms everywhere.
Diving right in, we wanted to talk to you about some guidelines or a statement that was published last year from the ASA, the American Society of Anesthesiologists, about pain during C-section. Tell us a little bit more about that.
Yeah, thank you. One of my other roles is chair of the American Society of Anesthesiologists Committee on Obstetric Anesthesia.
Okay.
So as information comes out, we wanted to highlight for everyone, anesthesiologists, obstetricians, patients, everybody to know that there's almost 15% of women who are having pain during cesarean section. So first thing I want to say is feel something, say something.
Oh, yeah.
And that to empower women to be prepared and to speak up. And sometimes there's a rush or emergency cesarean section when the incidence is higher because they have to get the baby out, maybe as a life and death situation. And there's not enough time really for everything to kick in fully. But certainly we don't want anyone to be in, severe pain, moderate pain, or even mild pain. So let us know so we can talk about it. In the statement, it goes through some of the history and different domains that you can try to address. There are people who preoperatively who would be at higher risk for this. And so you want to identify that, educate everybody, patients and medical professionals as to the problem. So you're aware of it, be tuned to that people may have had prior traumatic experience in their past, and that can affect what's going on and how they interpret whether it's pressure or pain. And that really to emphasize the shared decision-making aspect of a lot of that. I mean, a lot of times during the cesarean, they'll say, oh, I feel something. And then it's like, well, is it pressure or pain? The patient will identify what they're feeling because no one but the patient can know what they're feeling, right? And then I say, you can offer, oh, would you like something for that? It may make you a little sleepy. And then a lot of times they say, no, it's okay. Yeah. They just want to know that it's all right.
Reassurance.
Yeah.
We used to be that you'd say, you're going to feel pushing, going to feel things, but it shouldn't hurt too bad. And if it's too bad for you, let us know. Is that still, I've been in doing OB for a long time, but that used to be the narrative.
So you're exactly right. In the past, the emphasis was protect the baby. Don't give anything that could go across the placenta and wind up where the baby wouldn't be breathing on its own. It would need resuscitation. And now we know most of the medications are pretty safe that we're going to use.
Yeah.
In terms of that, and the emphasis is changing now that we know that there's such a high incidence, 15% or so varies, of pain during cesarean. We want to take that closer to zero.
But in the last century, the bailout option used to be it's okay to say I've had enough and we can put you off to sleep. Is there a reluctance to do that now?
Yeah, well, there is a reluctance in terms of you want to see and have the memory of the baby coming out. But there are certainly things you can give that would help to bridge in between, either giving more local anesthetic through the epidural, if someone's at high risk, using a different, altering your technique a little bit, even surgical administration of some of the local. So it depends on at what point during the surgery.
Right, and that's all in the statement that we can find. Where do we find it?
It's available to anyone on the ASA website, asahq.org.
We'll put that on the show notes and link out the statement there.
Yeah. And this year we're working on a follow-up statement, which isn't out yet. It needs to be approved in October at the House of Delegates, but it's adjuvant use for pain during cesarean. So it defines out the multiple steps of things which you can give, so that here at SOAP, most people are doing a lot of OB and they may be more comfortable, but throughout the United States or internationally, the occasional person who's covering may not know, you can give drug A, B, C, or D, and sort of the different tips. So it's going to outline everything to help empower the average practitioner about what's okay or not.
Because the occasional OB practitioner, I'm guessing, does a fantastic job, but they wouldn't necessarily be right up to date with those new options.
Yes.
Yeah.
Great. Thank you for that.
Well, and having kind of, I always say the easy button, just the sheet of things that I can go to refer to.
Right. No, it's okay. Because a lot of what we give is not, FDA approved for that route of administration at that time.
So a subject I'm quite passionate about, NPO. Okay. So I did my training at the Middlesex Hospital in London, which is where the Selleck maneuver came from. Yeah. So I know exam questions used to be how hard you press on the cricot. So I thought that all related to pregnancy. I think that relates to originally and solid food getting into, but in enhanced recovery, they've liberated NPO.
Yeah.
Now, more recently, we've had some of the drugs to help obesity, diabetics, exactly. We're back to full stomachs. You're in a debate tomorrow about the pro and con. And what's the question? And are you the pro or the con? And as often in debates, do you actually believe strongly one or the other?
As a professional debater, I can take Exactly.
That was a nice back answer there.
But yeah, it's as we have more information, it's definitely changed to both. Cricoid pressure, as you mentioned, may not be as useful as we once thought, not as protective. But it's certainly true that with gastric ultrasound, that we're finding that people have stuff in the stomach almost no matter what you've done, which is what we've experienced clinically, right? As someone throws up on you even though they haven't eaten for many hours. Yeah.
There always used to be carrots in there. I don't know what it is today, but of course the English joke was no matter what you eat, there's always carrot. Anyway, we know the point.
Yeah, so it's an important topic. A lot of people are concerned about it. So we did do oral intake during labor statement.
Yes.
2 years ago.
Yeah.
And that was also joint with ACOG and so the ASA statement. So it really looked at things and took a little bit. You have to prioritize safety as well as patient experience. So the recommendation is clear liquids in labor. The clear liquids can include protein. So some of those protein simple or complex carbs are okay. It can have, some protein in the solution as long as it's clear. That for sure is fine. And you process that, and that's...
But a heavy milkshake, not.
Smoothie, maybe not smoothie.
Okay.
Right. So, it came up because there's as several years ago, there was a OB study that said you can do elective induction at 39 weeks, and the outcomes are not just similar, but a little bit better in some aspects. And so it became very popular to do elective inductions. But then that's a longer process. So do you really want someone to be there for potentially 2.5 days not eating?
Yeah.
So that brought up, what do you do with the early labor component? So I'll just say that you're welcome to go to the statement and read it, but there's really insufficient data to say if you're coming in and you're going to get, misoprostol to ripen the cervix, followed by maybe a Foley bulb balloon to dilate the cervix, followed by oxytocin, and now you're already 36 hours into it. In the very beginning, is it okay to eat? And there's not really evidence for or against saying you could eat in that super early part. I think the consensus was not to be eating solid food during labor, and then to avoid, in high risk patients, and there's a list of what would constitute high risk in the statement, you may want to choose to limit food earlier.
So I mainly became a sort of critical care doc, but we were very close to the high risk OB unit. And most of the starvation ketosis that I've seen has been in mums that have laboured for a long time, if you see what I mean, because giving some form of energy didn't seem to be on the priority list. So you could go a couple of days without really getting any food of any form, which might need to be intravenous, might need to be glucose or something. Where are we on that?
I mean, you are allowed clear liquids, which includes Jello, includes, carbohydrate, sugars, simple sugars, the more sports drink with protein. The interesting thing was that whether you fed people or not, there was no difference in outcome in terms of cesarean section rate, et cetera. The main study people quote, I think, is O'Sullivan.
Not my specialist area.
Yeah. Anyway, so it was over 2,000. It was almost 2,500 women randomized food, no food, and no difference in outcome in terms of RET. And as well, you come to the pro-con debate tomorrow. There's even like a high calorie, low calorie, no difference. It's just not. Yeah. So it's not really, even though we say MPO, it's not truly nothing.
No.
Right.
So it's sort of clear liquid, stay hydrated,
Yeah. Gotcha.
So my answer would be, stay away from the solid food at least. And, 2022, there was that nice ultrasound study. I think Bouvet was the first author, if I'm pronouncing it correctly, from France, where they looked at gastric emptying, in labor. They had a non-pregnant, pregnant, in labor with epidural or no epidural group. And so actually the epidural group had faster emptying of the stomach. So the pain of labor puts out catecholamines and probably inhibits the labor.
Gastric stasis.
There was a presentation even yesterday from the Stanford group about gastric ultrasound for immediate postpartum tubal ligation. So they looked at ultrasound content and 1 hour after delivery.
Yeah.
And, half the women had volume in there. Yeah.
Yep.
So
tract produces of the stomach produces a lot of volume on its own.
Right. So people think, in this debate, people will turn to something like the SOAP, Serious Complication Registry study from 2014. Bob D'Angelo was first author, where it said there were 0 aspirations in 5,000 general anesthetics, and say, look, it doesn't happen. But since then, there was the ASA closed claim study on aspiration. So there are aspirations. They're just fortunately not very common.
But it's back in the news, really, isn't it?
It is. Yeah, but it's in GLP-1, I think.
Yeah.
Agonist.
And even though it was a recent study from the surgical literature, JAMA, one of their derivatives, Open, where they looked at, even if you follow the current ASA guideline about the GLP-1s, that there's still oftentimes stuff sitting there.
Oh, yeah.
So, it's a little bit of a quagmire because clearly it's a lot more common than we thought. Fortunately, we're not seeing a lot of aspirations. So where do you draw the line?
Dr. Selleck was looking far into the future when he suggested the maneuver.
Yeah. There you go. Mark, thank you so much for taking the time out of this.
It was a pleasure being interviewed by you two.
Yeah.
Just happy to see again.
Yeah, great. Well, congratulations on a wonderful meeting here. I know you're still involved with SOAP, and this is a great organization. So,
well, thank you very much.
Yeah, cheers to you. And thanks for listening to TopMedTalk. You can find us at TopMedTalk.com. We're on all your favorite social media platforms, X, LinkedIn, Facebook. We are there. We're recently on YouTube. If you find us on YouTube, give us a thumbs up, subscribe to our channel. Every little bit helps. Thanks again to the SOAP organization for giving us this fabulous space here at this wonderful meeting. Thanks for listening. Cheers.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.